Okay, I'd like to welcome everyone to Resnik Grand Rounds, February 26th. I'd like to thank everyone for coming tonight. I know everyone probably had a long day, but we have some really, really good cases to go over. And as you know, as for all the Resnik Grand Rounds, we have Dr. Hussein Tarek. He is our CBCT expert, as you know from ITX. He's a prosthodontist and their chief clinical director. Also, we have Dr. Rick Robinette. He is our clinical director at the Resnik Implant Institute. And if you can please keep him busy, he likes to answer questions. So on the chat, just put down any questions while I'm lecturing, or we're going over cases, and he is ready to answer your questions. With that being said, I'd like to get started. As you know, I always start with a controversial subject in implant dentistry. Tonight is going to be sorry about that. Okay, tonight we're going to talk about Jurnavics. If you haven't heard, the FDA just approved the first pain medication in over 20 years. This is due to the opioid crisis, and this is a non-opioid medication for moderate to severe pain. Why we're going to talk about it tonight is we're going to go through how it works, and we're going to kind of give you a take-home message on what you should be doing now. It's only been out about 2 weeks, but it's getting a lot of press. With that being said, as I said, it is the responsibility of the ADA, AMA, and the state boards to evaluate narcotic use. And if you look at the latest studies, the two latest studies that I have here are from 2015 to 2019 and 2016 to 2022. You can see dentists are prescribing a lot less opioids, and because of this opioid crisis. However, we are still number 6. If we look at all medical personnel, all the different modalities in medicine, we're still at number 6 for prescribing the most opioids. What is troubling is this study. This study shows that the narcotics that we do prescribe, about 54% of those narcotics go unused. And usually they go in people's medicine cabinets, and that leads to this. This is a study that shows that people who abuse narcotics, usually over 50% of them obtain from a friend or a family member, usually in one of these medicine cabinets. So that is very troubling. And that's why, if you look at the state boards, the American Dental Association, the American Medical Association, they have all mandated new guidelines on the use of narcotics. What have they actually done? They have started the prescription drug monitoring program. So they track every narcotic script that you write. Also, in most states, you have to identify high-risk patients. So it's up to you to be able to evaluate those and see those type of patients so that you don't give them scripts that could further put them into an opioid issue. Secondly, a lot of states now have mandated maximums. The majority states have a 7-day limit. Other states now are down to 3 days. So there is regulatory limits on how much you can prescribe as a narcotic. And then lastly, there is a huge push for these non-opioid pain medications, and that's what we're going to basically talk about. So as I said, this just was approved on Jurnavics, and it's 50 milligrams. It is a non-opioid for moderate to severe pain. And the FDA has just approved this for the use in all modalities in medicine. If we look at how it works, it actually doesn't work like a narcotic, which is centrally acting. This works peripherally, and it basically blocks nerve transmission action potentials in the neurons. So what ends up happening is it prevents any pain sensation. So it masks the pain for the patient. If we look at the benefits, as I said, it's non-opioid. So that is a positive. There is no dependency, at least right now. The studies that they have out there are showing no dependency. They are for short-term pain use, which is very good for what we do. And they're peripherally acting, so there's no CNS effects or minimal CNS effects. However, there are some disadvantages to this. What are some of the disadvantages? It's not well studied. It's brand new. It is, as I said, this is the first drug in 20 years. However, they have very, very few studies, a couple clinical trials on this. It is very questionable how the efficacy compares to hydrocodone or oxycodone. So it's very questionable on that. And it is a higher cost. So those are some of the disadvantages. Let's look, though, at some of the other non-narcotics that we've been using or should be using. The first is ibuprofen. Everyone's used to this drug. What it does is it inhibits cyclooxygenase 1 and cyclooxygenase 2. What do I mean by that? If you look at this little diagram, whether you lay a flap, whether you're placing an implant, any trauma to the body releases arachidonic acid, which is a fatty acid. That is broken down by two enzymes, which are called cyclooxygenase or COX-1 or COX-2. This produces prostaglandins. Now, on the left, those are the good prostaglandins, the COX-1. So on the right, those are the bad ones. They cause the pain and inflammation. The ones on the left help with our stomach and also with platelet activity. If we look at what happens with ibuprofen, it inhibits cyclooxygenase 1 and 2. So what happens is not only does it prevent pain and inflammation, but it also affects our GI system and also our platelets. So there are disadvantages, as everyone knows. If we look at the ADA has come out and said, no more narcotics is our first line therapy. So when we have a patient who is going to be in acute dental pain, their philosophy, their position is non-steroidals. So something like a ibuprofen. Only do you go to opioids if the non-steroidal fails. And that is the current ADA position and the position of most state boards. If we look at another non-narcotic, acetaminophen. Now, acetaminophen works a little bit differently. It doesn't work on COX-1 or COX-2. There's actually a COX-3, cyclooxygenase 3, in the brain. So this is more centrally. It blocks the pain signals. So it's a little bit different than the non-steroidals. If we look at the mechanism, it blocks this COX-3 on the right-hand side. And because it's centrally acting, that's where we get the fever reduction. So Tylenol is better to reduce fever than ibuprofen. If we look at the combination, and this is what I want you to understand, the combination is the ideal solution. If we look at adding ibuprofen and acetaminophen, COX-1, COX-2, and COX-3, they work great together. If we look at reducing COX-1, COX-2, and COX-3, you can see there is different mechanisms to prevent pain, prevent inflammation, and to prevent fever. If we look at some of the studies, and there's some really good studies. This is one from Compendium. This is a study that showed combination therapy, ibuprofen and acetaminophen, works far better than narcotics for dental pain. Probably the best study out there is Dr. Paul Moore, who actually taught me pharmacology in dental school from the University of Pittsburgh, did a great study. And this is the one that was printed in the JADA, American Dental Association Journal. What he looked at is ibuprofen 400 milligrams, acetaminophen 1,000, and he compared that to all opioids. And he found that ibuprofen and acetaminophen together was more effective than any other opioid. So that has really changed how we treat these patients. This is from the JAMA. This is from the Journal American Medical Association. They have also done studies, and this is from the emergency room department. And what they found in their study is ibuprofen acetaminophen works just as well as oxycodone, hydrocodone, or codeine. Therefore, those are three good studies that have shown that this ibuprofen acetaminophen mix works. And if you have been with our institute for probably the last 2 years, you can see that we have used this regimen for at least 2 years, and it really works because it's decreased how much opioids that we actually use. If we look at Advil, Advil came out with a dual action, and people always talk about this. What I don't like about it is the dosages. It's a really, really a low dose. 250 milligrams of acetaminophen, 125 milligrams of ibuprofen. Now, you can take multiple medications, but I think the easier way to do it is to I have two options for you, but before we talk about that, you have to understand the maximum daily doses. Ibuprofen, the safe maximum is defined as 1,200 milligrams. However, under supervision, the definition of under supervision is under the supervision of a medical professional. It can go up to 3,200 milligrams. Acetaminophen, safe maximum is 3,000. Under supervision is up to 4,000. That leads us to two different options here. This is my favorite option. This is what I do. I have patients alternate ibuprofen and acetaminophen. Ibuprofen 400 milligrams, acetaminophen 1,000 milligrams. That way, that patient every 3 hours is taking a dose, and it's really works well. If you look, it is under our safe maximum of 1,200 milligrams of ibuprofen and 3,000 of acetaminophen. Another option is to do 4 times a day. So every 6 hours, you're going to take in combination the ibuprofen and acetaminophen together. Now, unfortunately, there's never been a study that has evaluated these different dosing schedules. What I found in my practice is that option one works very good because patients, there's a psychological component of this. Every 3 hours, they're taking the medications. The one thing that you have to understand, though, is there is ceiling doses. Ceiling dose is defined as the dose, the maximum dose that you can give where you get no more effect. Ibuprofen has a 400 milligram ceiling dose. What does that mean? If you give more than 400 milligrams, the patient is not going to have any greater analgesic effect. Acetaminophen, it's 1,000. Now, ibuprofen does not have a ceiling effect for anti-inflammatory. It's only analgesia. When you look at this diagram on the left, morphine has no ceiling dose. That's why the more narcotic you take, there's no ceiling dose. That's why people end up in respiratory depression because there is no ceiling dose. The more they take, they then get adverse or problematic issues because of the dosage. With that being said, the last non-narcotic that we use, and anyone who has gone through our institute from the last 30 years knows that we have always used dexamethasone. This is probably one of the most underutilized drugs in dentistry and probably one of the safest and the best. We usually use in tablet form unless you do IV sedation. Then you're going to use the liquid form. Why do we use dexamethasone over methylprednisolone like Medrol or prednisone? Because it is anti-inflammatory. It is significantly more anti-inflammatory than any other steroid. If you look at the studies, reduces pain and swelling, and also there's two studies here, it reduces the amount of pain medication. Therefore, if you've ever used our cocktail for pain medication, you know that very rarely do you ever have to give a narcotic anymore because the use of dexamethasone and the combination therapy works very good. Now, dexamethasone works a little bit differently. It doesn't affect the COX-1 or COX-2. It affects the release of arachidonic acid. So it cuts out that pain and inflammation right from the very beginning. If this is the pharmacologic protocol for some of the doctors who are coming to our module 1 in 2 weeks, we're going to be going over this. This is the pharmacologic protocol that we've been using again for over 30 years. We define what medications the patient gets from their ASA classification and the invasiveness of the procedure. So you can see where we use dexamethasone. It's also called Decadron on almost every patient, not only for anti-inflammatory, but also to reduce the pain. And that leads us to what is the take-home message? The take-home message is Journavx is a new medication. Everyone's jumping on the bandwagon about it. Let me tell you, there are some limitations to this. It's not well studied. And because it's not well studied, you have to be very, very careful. What do I mean by it's not well studied? There's 2 phase 2 studies that showed Journavx is a little bit less efficacy than hydrocodone. In chronic pain, Journavx was no better than a placebo. So that is a little discouraging in the phase 2 and phase 3 studies. If we look at the studies I just talked to you about, there's 3 very good studies of combination therapy that is actually better than narcotics. So we know that combination therapy works very good with very few side effects. We know that from the phase 2 and phase 3 studies, Journavx doesn't work as well as the narcotics. Therefore, that leads us to we need a study for Journavx and Advil and Tylenol, which that has not been done. Therefore, until that is proven, I believe the cost is prohibited here. This is from GoodRx. Just one tablet of Journavx is anywhere from $24 to almost $40. So it is cost ineffective here. My recommendation is you still follow our pharmacologic protocol. As you can see, the pain control protocol, we use combination therapy, mild to moderate, and then if we have to, we can add hydrocodone in if the pain is increased. However, I will be watching this. We will modify that according to the studies as we get closer. So with that being said, that took a little bit longer. We have 5 really good cases here. So I'm going to send it back over to Dr. Hussein. And Dr. Hussein, let's go for it. Who's our first doctor?
Yes, sir. First doctor is Dr. Haley. Dr. Haley, would you
Okay.
mind unmuting yourself, please?
Dr. Haley?
Hi, can you hear me?
Yes. How are you, Dr. Haley?
Good, how are you doing?
Good, good. So what do you have for us tonight?
Okay, so we have a patient, and there's 3 areas, number 21, 20, and 29. 21 was extracted and grafted this past July,
Okay.
and so we were looking to place implants in those 3 spaces.
Okay. Did you do the grafting?
I did do the grafting for number 21. The other ones were pre-existing.
Okay. So what did you use for the grafting, Doc?
I did the 70-30 mix.
Okay, perfect. Perfect. Okay, so let's take a look. Dr. Hussein, can you go ahead and remove the teeth?
Yes, sir.
So, Mary, what we're looking at is how much bone resorption we've had. So it looks like the ridge is not too bad. So it looks like where the implants need to be placed, even though we've had a little buccal to lingual resorption, it's not bad. So what I want you to do, let's go to the panoramic image.
Right away, sir.
Okay, and good. Now let's do one at a time. So why don't we do 29 and see what the cross section of that looks like, Mary? You haven't done the
Hearing.
case yet, have you, Mary?
No, I haven't. I
Okay.
was worried about 29 because it seemed pretty narrow.
Okay. I think you're going to be fine. Hussein, did you put an implant in this?
Yes, sir, I did. I did add a 3.5 implanovi here at the side of number 29. It's a 3.5 by 11.5, Dr. Resnik.
Okay. So yeah, Mary, you're good. Now the only thing is, Mary, do you see the bone density there?
Yes, there was
Okay.
that one area that kind of jumped out at me.
Yeah. So the good news is you have some good cortical bone. We know that we get our primary stability from the cortical bone. So that will be fine. You have really good cortical bone actually on the buccal. So where he has that implant is ideal. That's perfect. The only thing I want you to do, Mary, is you remember the D3, D4 protocol?
Yes.
Okay. I would probably under prep this at least one burr, possibly two burrs. Okay. The reason is you have very little cancellous bone there. So we want to osteodensify it. So I would just probably cut out one, possibly two burrs. And I think you'll be fine there. You have plenty of bone. You're way away from the nerve. You have great distance from the lingual plate. This is a home run. No
Okay,
problem.
perfect.
Okay.
That's good to
So
hear.
yeah, so let's look at the other side. I think the other side might be a little bit more, well, not really. Okay, so your bone quality is better here, Mary. So I would still do a D3 surgical protocol on this one. What tooth is this one, Hussein?
That's implant number 20, Dr. Resnik.
Okay, so 20, you're you you're not even into the lingual cortical plate. You have plenty of bone on the buccal. I think it's good. So you're fine there.
Okay.
Let's look at 21.
That's 21 area, Dr. Resnik, a 3.5
Okay.
by 11.5.
Okay. Mary, was this a four-wall socket or a five-wall socket?
This was 5 wall.
Five-wall. Okay. And when did you graft that again?
It was this past July.
Past July. And when did you take the scan?
The scan was, I believe, from December.
December. Okay. So I think you're fine. This would probably more be a D4 protocol. So the bone density, as you can see, the apical 1/3 is not as great as the number 20 site. So what I would say is, yeah, right there. So I would just under prep this again, at least one burr, possibly two, and I think you'll be fine. But the
Okay.
graph looks good. It looks good.
Okay. Thank you
And
so much
you
for
did,
looking at this.
yeah, you did a nice job.
Oh,
So,
thank you so much.
and if you want me to look at this, are you going to do this guided, Mary?
Uh, well, I was gonna do guided with the pilot drills.
There you go. Mary's my hero. I love it. Yeah, it gives you, for the people who don't know what that means, is pilot drill, use the template for the first drill, and then you take the template out and you do it freehand. So it gives you your buccal lingual mesial distal and your depth for the first drill, the second you do it. So you get the best of both worlds, the guided and the freehand. Very good, Mary.
Thank you for your help.
Okay. Take care. Okay, let's see. Hussein, who do we have next?
Next is Dr. Jason Kwok. Dr. Jason, would you mind, sir, unmuting yourself, please? And Dr. Resnick, to give you a history about this one, sir, Dr. Kwok mentioned that the patient does have amelogenesis imperfecta. Currently, he has no medications. He's planning on extracting all of the remaining upper dentition, and he is considering an FP1 for the maxilla and an overdenture for the mandible, sir.
Okay, so I let me just I don't know if I heard all that. So the patient has amelogenesis imperfecta.
Yes, sir.
The maxillary teeth are going to be removed, and the prosthesis on the maxilla is a fixed detachable, so an FP3 most
Uh, for the
likely.
for the maxilla, it's going to be an FP1, sir. For the
Okay,
mandible, he's planning, or Dr. Kwok is planning on overdenture, doc.
okay, an overdenture. Okay, so is Doc on?
Yes. Can you hear me?
Yeah. Hi, Jason. How are you?
Good. How are you?
Good, good. So, Jason, first of all, how old is this patient?
She's 35.
35.
Mhm.
Any medical issues?
No, no medical issues.
Okay. So, Hussein, you give us a better pan than that?
Yes, sir.
Okay. So, Jason, is this one of the cases where the patient has amelogenesis imperfecta? They've tried to keep the teeth for as long as they can. Now these teeth are decayed, broken down, and need to be taken out.
Yes, doc. So the patient's had two implants were placed on the mandible 10 years ago, and
Okay.
she's not been wearing an overdenture for a long time, ever since the implants were placed. And a dentist placed an implant on number 9,
Okay.
recently. But
Uh,
if you see her photos, she has a very excessive gingival display. Um,
okay. Is it maxillary excess?
maxillary access, correct.
Okay. Okay. So Jason, or Hussein, why don't we take a look at the 3D images? Let's see what we have, Jason. Then we'll
Mhm.
come up with a treatment plan. How's that? Okay.
Sounds good.
So that's the maxilla.
Yes, sir. That's the
Okay.
maxillary arch.
Okay. Let's do a 360 so everyone can see it. And okay. Perfect. And let's see what the mandible looks like.
So that's the
Okay.
mandibular arch, Dr. Resnick.
Ooh, wow. Okay. Um, okay. Jason, let's first talk about okay. Let's talk about the prostheses. Jason, why fixed prosthesis on the upper and an overdenture on the lower?
I think it would help us if we can see the photo. Um, the photos will tell us more than, I mean, first of all, she wanted something fixed in the mouth,
Okay. Okay.
and she shows a lot of gum when she smiles. So I was thinking
Okay.
maybe we can do a lot of plasty and then hopefully shoot for an EP1.
Yeah. Okay. So here, let me do this, Jason. This is on a scale of 1 to 10. This is a 15 difficulty. So let's do one arch at a time. This is going to be an actual great learning case for everyone. So let's get rid of the maxilla first.
Yes, sir.
Okay.
Do you want to check the mandibular
No,
arch first
yeah,
of all?
yeah. I just want to see the mandible if we could,
Yes, sir.
Hussein.
Let me load the mandibular arch for you
Oh,
right
I'm
away.
okay. So here's what I'm looking at, Jason. This patient's 35 years old.
35.
Okay.
All right.
To be honest with you, this mandible looks like they're 75. Okay. So
Mhm.
what I'm worried about, let's once he gets it up, everyone will be able to see. This is a really good case. Really.
Here we go, Dr.
Oh,
Resnick.
wow. Okay. Do a 360 on us. Okay. Okay. So for some of the doctors who have been listening to the video lectures, we talk about um, different types of bone. This is a D1 type of bone. So let's look straight on at it, if we could.
Here
This
you go,
is
sir.
mainly basal bone. Okay. So Jason, my first problem that I have with this patient's not wearing a prosthesis, so their maxillomandibular relations are lost. Number two, it's an overdenture. So I believe you're a prosthodontist, so look up these two studies. They're pioneering in prosthetics. One by Dr. Reddy and one by Dr. Wright. And what both of them did is they did two studies evaluating a fixed prosthesis versus a removable prosthesis. And what they found is when you use the Brandenmark technique, 5 implants between the foramens, you actually in the posterior mandible will keep the same amount of bone or increase it a little bit. Now you might say, how in the heck do you increase the amount of bone in the posterior max mandible? Well, you do that because of biting force. When you have a fixed prosthesis, the biting force goes up dramatically, even more than when you had natural teeth. This patient has an overdenture that's not wearing an overdenture. Their biting force is less than 50 pounds per square inch. So, with that being said, Jason, my problem is if this patient's restored with an overdenture, I'm worried in 15 years, they're going to end up with a pathologic fracture in the posterior here. I mean, like I said, that's a 75-year-old patient we're looking at right there. So they've had significant bone loss here. I would be more apt to, let's take a look at these implants. First of all, they don't even look, I don't like where they're positioned. You said they were placed like 10 years ago?
Yes, 10 years ago.
Okay.
And it looks like they're
That's the
both failing.
Say that again, Jason.
It looks like it's failing if you look at the cone beam.
Yeah, that one is on its way to failing. Let's look at the other one.
Right away, sir.
Okay. Go back and forth. Okay. And that one is really failing. Yeah. Okay. So with that being said, Jason, does that make sense? The mandible, where if you do a removable prosthesis, their biting force is not going to be increased and they're going to have a definite problem in the future. Let,
Right.
let me show you another thing, Jason. I bet you this is going to be D1 bone. Can you look right in the center? Let's look right in the midline. It's usually what I like to look at. Perfect. Okay. So everyone who's listening to the online lectures, I talk about D1 bone. That is D1 bone. Okay. That's usually basal bone. That is very hard load bearing bone. How do we treat that differently? Well, the problem is there's a poor blood supply to that. And a lot of times you'll overheat this type of bone. So it's very easy to get early implant failures. However, it does look like we have enough height. Can you give me a quick measurement there?
Yes,
See how
sir.
much bone we have? Oh,
It's
plenty.
approx.
So, okay, let's look. Okay, now, Jason, as you know, the bone level will go down from the midline to the foramens. Let's look right in front of the frame and see how much bone we have on each side.
Here we go, Dr. Resnik. That's the right side, sir. And
What does that say?
it's
14?
14.5, sir.
Okay,
Yes, sir.
perfect. Okay. And the other side's probably going to be the same.
Left side is, sir.
That might even be a little bit more. Okay, perfect. Okay,
16.6.
okay. Okay, so let's table that one for a second. Now let's go upstairs. Let's go up to the maxilla.
Right away, sir. And Dr. Resnik, by the way, I did extract the
Oh,
pictures. So
okay.
I got them on my PC, sir. If you'd like to take a look at them, maybe till that one loads.
Yeah.
I'm gonna
So
scroll through.
so this patient, Jason, actually needed orthodontic surgery. Or that is an option too. So but I think we could accomplish the same. Do you have a patient or do you have a image where the patient's smiling? Just a smiling without the retractors in?
That's the only picture, sir.
Okay. Okay. Let's go to let's go look at the maxilla. Let's see how bad these teeth are. What type of so what I'd like to do, Jason, is let's start on number 2. Is
Here
there a
you go,
2
sir.
there? Okay.
Now
Or is
it's
that
number
3?
3, Doctor. It's number 3,
Okay,
sir.
go back. Okay. So what I'm going to have him start from 3 and go all the way over to 15, and we're going to see what the teeth look like. Okay, 3 is really bad. Keep going. Keep going. 4 is bad. 5's not too bad, but there's no bone. 6 is not healthy. Keep going. Keep going. Okay.
7.
7,
Romani Grudak number 8, Dr.
8.
Resnik.
Okay.
And Ealing
No.
implant number 9, sir.
Oh, Jason, that's failing too. Okay. Let's keep going. Keep going. Keep going.
11, sir. 12. 13 remaining root. Then we've got number 14, Doc.
Okay. So let's look at the pen again on this.
Here you go, sir.
Okay. So, Jason, you weren't thinking of doing this immediate, were you?
No.
Okay, good. Perfect. So for the other doctors on the call tonight, the reason you don't even want to think about doing this immediately is because of all the infection and the amount of bone that's going to be left is going to be very compromised. Now, what needs to be done on this case is a rather significant osteoplasty. So, here's what I would recommend on this case, Jason. So I like to do things in phases. Okay, so phase 1 would be the first part of treatment is it's going to be extract the teeth. You're going to debride all those areas. You're going to make sure that you have good bleeding sockets. If you have to, you're going to decorticate it. And then you're going to graft. You're going to graft all those areas. Now, the most important areas that you want to have for maxillary fixed prosthesis is it's what we call key implant positions. The first key implant positions is the cuspid. Why is that a key implant position? Because we're going to have mutually protected occlusion, cuspid disclusion. So we want an implant in the cuspid area. So you have to make sure that you graft that very well. Secondly, we want to minimize any cantilevers. So we try to get an implant in the molar area. You have tons of bone in the molar area under the sinus. I don't think that's going to be a problem. You'll never have to do sinus grafts on this, but I would still graft the sockets. And then the next area is usually the one of the bicuspids. I prefer the second bi because there's greater biting force second bi versus the first bi. So with that being said, in the anterior, depending on the patient's arch form, will dictate if we need an implant in the anterior. Now, I believe that Hussein, you said that there were 6 implants that were going to be placed.
Yes, sir. According
Okay.
to Dr. Jason's notes.
Okay. So Jason, just to be careful on cases like this, I would always leave that open-ended because you might need one in the anterior there. If it's a square arch form, we don't need one because there's no anterior cantilever. If there is a tapering or an ovoid arch form, we need one. So if I had a crystal ball, I'm going to say you're going to need 7 implants ideally on a case like this. This patient's 35. They're very young. You probably want to over-engineer this than anything. However, there's going to have to be an osteoplasty done on this case.
How
So
much osteoplasty do you think she'll need? Looking at her
exactly,
smile lines.
exactly. So what I would recommend is that you bring the patient back in and take photographs at rest, okay? Take multiple photographs, also profile photographs. Then take a minimal smile and a high smile. Then show this to me. We'll sit down and we can calculate how much of an osteoplasty you have to do via the CT scan. It's going to be rather significant. But what we can do on this software is we can actually determine where, even before you take the teeth out, we can determine how much osteoplasty you need because we're going to know where the implants are going to go. This patient might end up with still a little bit of a high smile line, but certainly nowhere near what they are now. Okay. They're at a significant issue there. I mean, that they're showing a lot of teeth, but don't put any retractors in because when you put retractors in, that gives you false positive, false negatives with the photographs. So I would get more photographs. We'll sit down. I'm going to say you're going to need at least probably 5 to 7 millimeters of osteoplasty on that. What do you think, Hussein?
Perfect plan, sir.
Yeah, but we can, and if you do the surgery, you can get a reduction guide, so it makes it really, really easy. That will also decrease how much bone grafting is done. Now, let me tell you on this case, the way that I would do this case, I would take out all these teeth, take out all the infection, and then I would take rongeurs, put the reduction guide in, use rongeurs, and go ahead and remove as much bone as possible. But you're going to save that because you can use a lot of this bone in the augmentation procedure. So you can get an autogenous component to that also. So that is phase 1. Also, you want to put an interim prosthesis in. You have to reestablish this patient's maxillomandibular relations. 3 to 4 months later, you're going to take a new CBCT and you'll take a dual scan. You always need a dual scan. Then we'll sit down and go through the key implant positions. Phase 3 will be a maxillary FP1, FP2, FP3, depending on the aesthetics of the case. Now, we have to get going to another case, but let me explain the mandible. The second thing I don't like about a maxillary fixed prosthesis versus a mandibular overdenture is what is your prosthesis material going to be? with an overdenture, it has to be an acrylic denture. Okay. That means that you're going to have to do a hybrid on the maxilla, which this patient's 35 years old. You want to use monolithic zirconia. Another reason to make this fixed. My recommendation on the mandible, take those 2 implants out. You can do immediate placement of 5 implants. That's a no-brainer, easy, make it a fixed prosthesis. The Brandemark technique, 5 between the frame and ABCDE. And you're going to see that patient will maintain that posterior ridge form, and they'll be fixed against fixed. Aesthetically, it'll look better. They'll maintain their vertical better. And because of the patient's age, I think that's the best thing. Okay. I know,
Sounds good.
Jason, that's a lot to go through. And like I said, this is on steroids, how difficult this one is. But do you have any questions on that? We can talk later about this, but
Yeah, I think I'm good for now.
okay. Does
think
that
that
make
aligns with
sense
what
what
I
I
was thinking.
talked about?
Yes, I think that aligns with what I was thinking
Oh,
about doing.
perfect.
Yeah.
Okay, good.
Mhm.
Okay. Nice case. Let's go
Thank
to the third case. Let's go.
Next case is for Dr. George Gracious. Dr. George, would you mind unmuting yourself, please, sir, and describing your case to Dr. Resnick?
Hi, Dr.
This is
Resnick.
interesting.
Hi,
Hey,
I'm
So you
Sam.
can, like,
George, how are
send him
you?
cases?
I'm good.
This is interesting. So you can like send him cases.
Okay, go ahead, George.
Okay, so Debbie, my patient Debbie is 67-year-old.
By the way, George just sent me an unbelievable sinus graft. The most difficult sinus graft you can do is a single, and he did an unbelievable. He sent me the post-op. When was that? Like
Monday.
was that Monday? Okay.
Monday, yeah.
Great, nice case there. That wasn't
Thank
easy.
you. The
So
patient is
I
still
see
feeling
you
well.
only treat posterior maxilla. So let's see what we have here. So what do you have for us?
So the patient, she had a bridge, fixed partial denture, 12 to 15.
Okay.
12 was failing, so I had to section the bridge. And I did the graft after I extracted 12 was extracted in June last year, and then I did the guided bone regeneration in October last year.
Okay.
I'm originally planned to do 12 and 13, and we'll have the cantilever on 15. But now I told her maybe she's better off doing 12, 13, 14, and split them together.
Okay. So am I looking at this correct? Is there a crown on 15 with a cantilever on 14?
Yes, this was part of the
Okay.
bridge.
Okay. Okay. And then on the other side, it looks like the patient.
She
Is that
has a
the s-
cantilever.
Oh, cantilever distally. Okay. Oh, look at that third molar.
Yes.
Okay. Yeah, leave that alone. Don't go hunting for that
No,
thing.
she's
Okay.
she's fine with it.
Okay. Let's look at a panoramic view.
Right away, sir. Here you go, Dr. Resnick.
Okay. So you did some bone grafting. Let's go ahead in the number 12 position and go distally and look at cross sections. So I'm going to have him go distally. We're going to start at number 12.
That's number 12 area, Dr. Resnick. I'm
Okay.
sprawling distally right now, sir.
Okay, keep going, keep going. Keep going. Keep going. Ooh, that doesn't look good.
No, it doesn't.
George, what's the deal with 15? That's not healthy, is it?
It's coming out.
Oh, it is? Okay.
Yeah, the new plan will take out 15 and place 12, 13 on 14 for her.
Okay, so let's take a look at how old is this patient?
She's 67.
Okay, good. Hussein, did you place implants on this patient?
Yes, sir. I did add implants
Okay.
on this patient.
Okay.
That's 12, 13, and
Let's
14, sir.
let's see what we have. Why don't we look
So-
at a cross section?
For number 12 area, Dr.
Yeah.
Resnick, I've got a 3.5 by 11.5 limited long implant, sir.
Okay, hold it. Okay. So there's a little bit of a lingual defect. That implant looks good. Your bone graft looks good. George, the only thing I would do is take the bone from the burr, the autogenous bone, add a little allograft, and you can graft that site. Grafting on the lingual it works out very easily. That'll be simple. But
Sure.
you have plenty of bone on the facial. And what size? That's 11 and a half.
That's an
Yeah.
11 and a half. Yes, sir.
Okay. That one's good. So that's 12. Let's look at 13.
3, 5 by 8, Dr. Resnick.
3, 5 by 8. Okay.
Yes, sir.
The bone quality doesn't look as good there, George, but that's doable. Let's look at 14.
14 is a 4.3 by 8 millimeter long implant, Dr. Resnick. We've got 5 millimeters of collarbone over here, sir, but we're going to need an internal sinus lift, doc.
So that's an 8 millimeter implant.
Yes, sir.
Okay. Hussein, move that implant out of there so I can show everyone this.
Here you go, sir.
So, for anyone who has not done an implant into the sinus, this case is ideal. That is inflammation. If you show them the inflammation in the sinus, that's a Schneiderian membrane. There's inflammation, so it's very thick. All it is inflammation. It's no real disease. You don't have to worry about it all. But what I like about it is you'll never perforate that sinus because it's a real thick membrane. That's the one, if you want to do your first sinus graft, that's probably it right there. With that being said, Dr. Hussein measured on the ridge, and show them that again.
Right away,
The
sir.
reason why he measured is 5 millimeters is the minimum for what we call an SA3 technique. And SA3 is where we place an implant and bone graft into the sinus, because he's being generous there. It's 6.1. It's probably a little bit less than the other images. So he does have 5, but we have a 8 millimeter implant. It's going to be our shortest one that we want to use. So he's going to have to do a internal sinus lift on this. If it was only 1 or 2 millimeters, we could just bump it up. But because it is going to be 2 to 3, maybe even a little bit more, I would do a internal lift on this. But let's go back and look at the scan pan on this again.
Right away, sir.
Okay. Now, George, if you look at this patient, they're 67, I believe.
Right. Yeah.
Okay. So when people look, and I know you plan 3 implants, which is good. You'll never go wrong by over-engineering. If this patient, let's say we weren't worried about 15, then you could probably get away with 2 implants here, because this patient probably has a low biting force. They're female, lower biting force. They've been walking around cantilevers. Doesn't look to be a problem. So you could probably do 2. However, if you want a implant in 15, then your plan was to do 3 implants and then cantilever on the prosthesis.
No, no cantilever. I told
So,
her you don't need the second molar. It doesn't get a lot of chewing.
oh, so you're not even going to put a second molar?
No.
Okay. 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 I was going to say that if you have 3 implants, you probably could cantilever that with a very narrow occlusal table and minimal cusp height. You could probably do that. If you're only going to the first molar, George, you could probably get away with 2 implants here. Okay. Because the patient doesn't look like biting force is going to be an issue. And that would be one option. But going with 3 is going to be a lot more predictable. So either or on
Right.
that. Now, what you could do, George, also is you could design that number 14 implant to have if you put 3 implants in, you could pick up the mesial aspect of that second molar on the mandible. Then you won't get any super eruption and you will get some occlusion on that. Okay. Does that make sense?
I don't really follow. Can you
Okay.
explain?
So right now, if you just put the implant where it is, you're going to have the number 14 is going to contact with number 19, right?
Right. Yeah.
So if you place 3 implants, you can put that number 14 implant a millimeter distally, okay? Bodily move it distally, and then pick up just the mesial part of that lower number 18. Show them just the mesial component of 18. Yeah, on the lower
I see. Yeah,
Hussein. Yeah, right there.
makes
So
sense.
that way you don't get super eruption of 18. Also, you'll get proprioception to 18 and it would benefit the patient.
Makes sense.
Does that make sense? So if you go with your 3 implants, that's what I would do. And so you're going to give them almost like 3 1/4 teeth.
I see, that makes sense. Then I'll have to extract 15, wait 3-4 months, and then replant the implant, replant number 14.
Yeah, yeah. I mean, so you were going to, well, 15, you could take 15 out same time you do the surgery if you want.
Okay, if I have enough bone, yeah, that would be great.
Yeah, you could just take it out. And I mean, preferably what I would do is I would take that out and then you have good free autogenous bone there that you could use in your internal sinus lift. Okay. Also, another option, George, would be see that little septum there? Go back, Hussein.
Yes, sir.
See that little septum? That's your backstop. If you want, you could even do a little lateral wall there. Even put a larger implant, like a 10 or 11.5. But because of that backstop, you grow a nice column of bone right there.
Nice.
Okay.
Yeah, makes sense.
Okay, good. Hey, nice case. Thanks for submitting that. Okay,
Thank you. Thank
I
you.
don't want to go over, so let's go next case. Patient 4. What do we have?
Dr. Middleton, Doc, would you mind please unmuting yourself?
Hey, Dr. Middleton can't make it tonight, but I'm working his office, so I'm happy to present the
Oh,
case.
perfect, perfect. Okay, Doc, can you tell us what you have here?
Yeah, so we have a new patient. He's a 34-year-old male with penicillin allergy, and he smokes less than a pack of cigarettes a day. He had a car accident 8 years ago and fractured 3 of his 4 mandibular anteriors, and none of them are vital. And so we're kind of exploring implant replacement options versus doing, root canals and crowns on all of them. And
Oh, okay. So you're talking 23 through 26, Doc?
yes,
Okay. So Hussein, let's look at a pan view.
Yes, sir.
Okay. So you have PA pathology on all 4 of those?
correct. And it looks
Okay.
like it's getting close to 27.
Yeah. Yeah. Ooh. Okay. Are the cuspids vital? Do you know?
Yes, they are right now.
Okay. Okay. Let's do a cross section from 22 or from the cuspid to cuspid. Let's see
Here
what we
we
have.
Here we go,
Okay.
sir. That's tooth number 22, Dr. Resnick. I'm going to scroll towards the
Okay.
midline right now.
Okay. Okay.
23,
Okay.
24,
Or
25, sir. And
okay.
that's number 26, Doc.
Okay, perfect. Okay, let's go to the 3D image. And let's
Here we
look
go,
at the
sir.
facial aspect of that.
Switch off this, switch on the volume render.
That's what I'm looking for. Okay. Doc, do you see that? There's no facial plate there.
Correct, yes.
Okay. So I would not even think of trying to save those teeth. So here is what I would recommend on this. Phase 1 would be extraction of those 4 teeth. At the same time, you would debride the area very well and then do socket grafting.
Okay.
These would all be 4-wall sockets. So it's going to be rather significant how much just to build that buccal plate back out. When you go to replace phase 2 would be after the bone graft heals. Now, did you place implants, Hussein, on this
Yes,
one?
sir. I did add 2 implants at the
Okay.
sides of number 23 and 26, Dr. Resnick. I'm going to present it to you, sir, on the cross-sectional image. And here you go, Doc.
Okay.
35 by 16, Dr. Resnick.
Okay. So, and let's look at the other one.
That's number 26, sir.
Okay. Let's look at a sagittal view of this
Here you go, sir.
so we can see the position.
Oops.
Okay. Okay. Well,
Yes,
I'll tell you what, here, let me make this easier. Let's look at an occlusal view.
occlusive view.
Okay, with the 3D. So, Doc, here's what I would recommend on this. Usually, when we're missing 23 through 26, we don't want to place the implants right up against the cuspid because what ends up happening is you lose the bone down to the crest module of the implant. Therefore, we put two implants in the embrasure 23, 24, 25, 26 coming through the cingulum. It'll be screw retained, 4 teeth, and then the implant is greater than 3 millimeters away from the cuspid, and then you'll maintain that mesial bone. Does that make sense?
Yes.
Okay. There. See if you can show the audience just a better image of that, Hussein. I just want to show because often a lot of people they try to place the implant in the 23 and the 26 position, and it becomes very problematic. I need to see a sagittal where you see 26 and 27 together.
Here we
Okay.
go, sir. So that's number 26 and number 27. I'm going to move it a little bit closer. Here
Yeah.
we go, doc.
Okay. Okay, that's a little bit hard to see. But anyway, what happens is you get remodeling down to the neck of that implant because in the mandibular anterior, the um, the buccal thickness, the buccal plate is usually less than half a millimeter. It's one of the thinnest buccal plates. You don't have enough bone even when you have teeth there, let alone when you don't have teeth. So usually you're going to place the implants vertically a little bit lower. Because of that, the emergence profile will be ideal because it'll be away from the cuspid. Okay, does that make
Yeah,
sense?
it does.
Okay, great, great. Okay, perfect. Let's go to the last case. I don't want to keep
Last
anyone late
case
today.
is for Dr. Paul Gabriel. Dr. Gabriel, would you mind unmuting yourself, please, and presenting your case to Dr. Resnik?
Good evening.
Hey, Paul, how are you?
I'm great, Dr. Resnik. How are you?
Good. How's snowy Pittsburgh?
It's warming up.
It
Warming
is.
up. Yeah, we're in the
Okay.
40s.
Oh,
So
there you go. Okay. So what do you have for us tonight, Doc?
I have a young lady, a 21-year-old female with some congenitally missing lower anterior teeth, no health issues, no drug allergies. I had seen her initially for a consult, and then she had come back to me with some bone grafting attempted here in this lower front. So this is where I'm at. And I did just do some treatment planning and implant placement on my own, but it's the implants have to be really deep.
Okay, so hold on. I'm missing this. Okay, so this patient came to you. The patient went somewhere else, had some bone grafting, came back, and now they want you to fix this.
Yeah, they were concerned as to what was done and just wanted an opinion.
Yeah, I'm a little
As to,
concerned
well,
about what they did. Okay,
yeah.
let's look at a pan view of this.
Right away, sir.
What teeth are those laterals going to be extracted?
Well, that was my plan, to extract the laterals and to have a 4-unit, two implant 4-unit bridge.
Okay, this is a duplicate of the case we just looked at. Okay,
Yeah.
so okay, okay, Paul. Here's let's look at an axial view of this.
Right away, sir.
You have an issue on this case, medical legal issue here. Okay, see there on the left, right there. Okay,
Yes.
they put a screw right between those two teeth. Why did they do that?
No idea.
Okay, so let's go back and forth. Show everyone why would they put a tent screw over there? They need a tent screw in the interior. Okay,
Right.
and they perforated too. So those are in the lingual. Wow. Okay. So Paul, I want you to medical legally, you have to be careful on this case. This is good learning, another good learning case
Okay.
for everyone. Um, First thing I would do is pulp test. Is that let me see again. Is that number 22, 23?
That's number 22, 23. Yes, sir.
Okay. Pulp test number 22, Paul. And what I want you to do is see this image right here that he has.
Yes.
I need you to show the patient that. The reason is that you have a periodontal ligament around the tooth, which is about 0.6 to 0.8 millimeters. They've severed that. Okay. So that means the blood supply is broken off. Scroll up and down. Okay. They might have even prepped. Okay. So the problem that you have is anytime you damage the periodontal ligament, you can get internal external resorption. Because of that, what ends up happening is this could be a time bomb later on. Let's look at a cross section and see if there's a defect there yet.
Right away, sir.
Okay. I know it's 8 o'clock, but this is wow. Yeah, that's not good. Okay, so those tent screws, those are Selvin tent screws. The threads on those are very aggressive. And so they're usually self-tapping. They probably have altered that mesial of the cuspid and distal of the lateral. And they probably removed some of the cementing on that. Now, in some cases, studies have shown that it can regenerate, but a lot of studies show that it doesn't, and it will end up with either an endo or possibly internal external resorption. So right off the bat, document this, show it to the patient, and you're just going to watch it. This is something you're going to have to watch for a long, long time, and they're going to have to be aware of it. But I don't want you doing this case and then this becomes a issue and then you get blamed for it later. Document it very well. And you have to inform the patient, okay? And that's what is standard of care. As long as you inform the patient, that's your get out of jail card. Now, with that being said, let's look. This is going to be a duplicate of that last case. I would take these laterals out. And you're going to need more bone grafting, Paul.
Yeah.
Okay. Okay. Did you know you already knew that?
Well, I figured that. Yeah. My concern was just, how much can I build up that crest and how wide can I get?
Yeah. So let me show
without
you.
getting the implants too deep.
Yeah, this is well. Let's look straight on here, right here on the pan or a sagittal view. Let's do a sagittal view. Okay, right there. Blow that up in the center.
You got it, sir.
Okay, here's what I'm going to show you, Paul. So, Paul, look right here. I want everyone to understand this. You put implants in 23 and 26. What ends up happening, show them what the crest module is. That's the top part of the implant. What ends up happening is on the mesial, that cuspid, all that bone will remodel. And what you end up doing is you put a perio defect on the mesial, the cuspids, and then you get a black triangle, you'll get a big black space. So why we never place implants that close to a cuspid is push the implant over, Hussein. So half of the implant is on the tooth, half is on the edentulous area, right there. Right there. Now measure it. If it's greater than 3 millimeters, you're going to maintain all that bone. Okay, you're at 3, and then the other, you're going to make it 3. And yeah, you might have to move that one just a little bit, hair over. Okay. So with that being said, now show them the 3D image from the occlusal view.
Here you go, sir.
Okay. So, Paul, you're going to have 2 implants in the embrasure, but you'll have 4 teeth on the prosthesis because you can't put more than 2 implants in. That way you preserve the bone and the soft tissue on those cuspids. You're going to have to take those tent screws out. And again, I would tell the patient the same issue on both sides there. Both cuspids are, they're close. So I just inform them of that. Okay. Does that make sense, Paul?
Yes.
So never place those implants next. Don't hug them up to the cuspid because what you told me is correct. You're going to have to put them vertically lower. If you place them in the embrasure area, it doesn't matter how deep you put them because your your emergence profile is going to be ideal, and you're in a non-aesthetic area. So the teeth can be a little bit longer. The patient will never show it. Okay. But to get like an FP1 prosthesis, it'll never happen.
Right. Okay.
Okay.
So what
Does
are
that
the
make
cross
sense?
sections of those? What does the cross section of the implant in that position look like?
I think it's going to be compromised. You're still going to need,
Yeah.
yeah. So see how thin it is? So remember, Paul,
Yeah.
you need 2 millimeters of bone on the buccal
Right.
and 1 on the lingual. Okay.
Okay.
So think of that. If you use a 3 millimeter, 3.5 millimeter implant, that is 6.5 millimeters. The buccal lingual diameter of a central or lateral is 5 to 5.5 millimeters. Okay, that's in health. So just think when you have the tooth missing. So you have to build it up wider. So it'll be an
Okay.
easy bone graft because it'll be very easy to get closure on it. So this is right up your alley. This will be
Would you use smaller 10 screws in there?
Yes. Or if you use the newer Selvin screws, you'll probably just need 1 on each side. If you use the older ones, you'll need 2. But
Gotcha.
you could use 1. The other thing is show them the perforation of that 10 screw in a cross section. Look,
Here,
so
Yeah.
this patient, think of this, Paul. This patient's walking around with a very sharp apical end of that 10th screw out of their lingual bone into
Right.
that
So
lingual
thin.
mucosa. Oh my gosh. I mean, that has to be really irritating, and the tissue is probably not too happy there. So, okay.
Okay. Yeah. Awesome. Thank you.
Okay. Hey, I want to thank everyone for staying on a little bit longer. Those were some great cases. Uh, in 2 weeks from now, we will actually be in Dallas because we have our CBCT boot camp and our module 1. So we'll be back with Resnik Grand Rounds in 4 weeks from now. Also, if you have a case, please submit them early. As we had like 2 or 3 later today that arrived that we couldn't get in. So everyone be safe and have a good night. Thank you, Dr. Hussein and Dr.
thank you, sir.
Robinette.
Thank you, sir.
Thank you, gentlemen.
Thank you.
Thank you, everyone.
Mhm.
Bye-bye.